Hand, thermal, electrical, or chemical burns. A patient of age 80 has been received at the A&E with a previous history of burns over the dorsum of the dominant hand. On history, he confirms that he was admitted at a bone marrow transplant unit where an IV site was placed at the dorsum of the hand. An administration of a chemotherapeutic agent was given at that time, and that has extravasated to the site through the line, resulting in the injury. Physical examination shows that there is subcutaneous tissue edema with cellulitis with some area of necrosis. The extensor tendons were noted to be covered by soft tissue and paratenon. A normal saline dressing had been applied while shifting the patient to local university hospital. A differential diagnosis of thermal burns, chemical burns, or electrical burns can be indicated in this case. This patient specifically might be possibly having a chemical burns because of extravasation of chemotherapeutic agent. Tissue necrosis and sloughing is known to occur with the extravasation of different chemotherapeutic agents, and tissue reaction has been known to occur at site distant from the injection site itself. Now, going to the approach, there are different methods to approach this patient, but a primary goal of any treatment of the hand injuries is to restore optimal function. There are multiple ways to treat a burn on the hand, depending on the thickness and extent of the burn and stated injuries. Several principles should be kept in mind. Early debridement, edema, infection control, early wound coverage, and early mobilization are critical for successful outcome. Superficial burns can heal spontaneously within 10 days. On the other hand, it is imperative that early motion that is required to prevent joint stiffness and reduce edema formation is required, but movement can inhibit healing itself. Any deep wound which takes more than 2 weeks to heal on their own should be treated by excision and coverage with a graft or a flap. To cover, a full thickness or a split thickness graft can be used successfully in treating both superficial or partial thickness burns of the hand. Furthermore, it has to be augmented by the use of Onna's boot dressing, fibrin glue, and even semi-permeable membrane dressings, all of which have reported to help improve the graft take. Prior to this, it's to be noted that tendon rarely accepts skin grafts, and therefore it may require a flap coverage after excision and debridement. Flap coverage is an excellent option in injuries of the hand because of the ability to cover the wound while providing a smooth surface to the joint and tendons and potential of early mobilization with physical therapy. Talking about the flaps, there are multiple types of flap which can cover the hand injuries. Each of them have advantages or disadvantages. Number 1, local flap. A local flap such as homodigital flap can be successfully used to treat defects of the hand. The benefit of this technique include one-stage procedure and the use of skin with similar thickness, appearance, and elasticity. The limitation of this flap is limited area of skin for coverage and ability to cover only over distal hand injuries. Another option, number 2, is a 2-stage groin flap. This flap has the advantage of ample suitable skin for coverage, but the resultant immobilization of the hand makes this option less appealing in most patients. Another option, number 3, is a neurocutaneous ulnar nerve/artery flap. Aside from similar skin characteristics, these flaps have reported advantage of preserved cutaneous sensation in the flap. Unfortunately, these flaps require a more involved dissection and limited experience with them. Another option, number 4, is a distally based radial or ulnar forearm flap. These flaps can cover large defects, provide skin with characteristics similar to the recipient site, do not require stage procedure or immobilization, and do not require extensive dissection or, in many cases, vascular anastomosis. Another option, number 5, is a free flap. Radial forearm free flaps from the opposite arm or the temporoparietal free flaps and split thickness skin graft have been described. The need for a vascular anastomosis and the risk of flap loss are the major disadvantage. These are the all decision making as per the reconstructive ladder. Each wound need different type of treatment and plan of management. It all depends on the extent, site of the wound, and aesthetic injury to determine the method of coverage. Now, considering that our patient had a deep wound at 5 to 7 centimeter wound, the intraoperative Doppler examination of the radial ulnar vessel confirmed previous angiographic findings. An operative intervention was planned in the form of a ulnar artery flap from the dorsal aspect. Prior to operative intervention, renal functions should be tested and patient should undergo angiogram of the right upper extremity. The study in our case revealed that the radial artery was a dominant blood supply to the arm. In addition, the palmar and dorsal arches were widely patent. In our case, the patient was shifted to operation theatre. The arm was accentuated and tourniquet raised to 250 mm Hg. Dissection of the ulnar artery was initiated next to the flexor carpi ulnaris muscle near the wrist. The ulnar artery was then clamped and the tourniquet released. A good blood flow in the hand was noted. An island of skin of the same size as the defect was marked over the ulnar artery in the proximal forearm. The remaining length of the artery was then freed from the surrounding soft tissues. Taken care to preserve the perforators of the skin island. The artery was transected in the proximal forearm, and adequate retrograde flow was observed in the stump of the ulnar artery with external capillary fill in the skin. The ulnar base fasciocutaneous flap was tunneled through the intact dorsal subcutaneous tissue of the wrist to cover the dorsal hand wound. The flap was then secured in position in 2 layers. The inner side was partially closed by undermining the soft tissue medially and laterally and allow for tension-free approximation of wound edges. The proximal wound, wherever was not able to be closed, a split thickness skin graft was utilized. After the procedure, volar splint was applied and stabilized the hand. A site on the flap was marked for future arterial Doppler monitoring. The patient was placed in perioperative antibiotics and enteric-coated aspirin. He was discharged from the hospital after 48 hours. Splint was kept for 7 days. The flap, both flap and donor site area healed without any complications. And the patient reported minimal impairment, if any, but he did exhibit 10 degrees of extension lag in his fingers. Talking about the burns and complications, there are many complications associated with the burns of the hand and could be related to the extent of the injury, the type of injury, mechanism, and method or treatment instituted. Skin and soft tissue contractures are common problems that result from several factors, including inadequate skin coverage, insufficient postoperative rehabilitation, or altered wound healing, that is, hypertrophic scar formation. Botonial deformities can result from soft tissue contractures over the dorsal aspect of the digit. If addressed early enough, splintage may be sufficient to correct the problem, but often arthrodesis is required. Another problem is a web space syndactyly, and this complication usually requires excision and grafting to correct it. Nerve injury is often seen in the electrical burns, and the ensuing fibrotic reaction may require neurolysis or even nerve grafting. Electric burns are another challenge because the extent of the burn is not apparent on the examination, and even far greater. Also, deeper structures are frequently involved with accompanying subfacial edema. This should lower the threshold fasciotomy should evidence of compartment syndrome arises.